Hi, my name is Ajai Chari. I'm a professor of medicine and director of clinical research at the Myeloma program at Mount Sinai, New York. And it's my pleasure today to talk to you about Talquetamab, a G protein coupled receptor family, C group 5-member D, what we call GPRC5D, CD3 bispecific antibody in patients with relapsed refractory myeloma, phase 1/2 results from a MonumenTAL-1 study. So Talquetamab is a bispecific antibody, which I think a lot of the listeners will have had a lot of exposure to. And importantly, the phase 1 portion of the study was recently published in the New England Journal of Medicine. And we found there a response rate of 64 to 70%. The study there was a combination of patients who got both intravenous and subcutaneous dosing at a variety of dose levels. Here at this year's ASH meeting, we updated the results of the MonumenTAL-1 study. And these are the patients treated at the recommended phase 2 dosing. There are 3 cohorts as shown here. 0.4 milligrams per kilogram weekly. Second cohort, 0.8 milligrams per kilogram every 2 weeks. And the third cohort could be either of those doses, but in patients who had previously been exposed to T-cell redirection therapies. This is important because it's an unmet need. What do we do with patients who've had prior bispecifics and CAR-Ts, but relapse after that? So the patient characteristics are shown here. They're pretty typical of a relapsed refractory myeloma study. They had about 5 lines of therapy over 6 years. A third of patients had high-risk cytogenetics. About a quarter of patients had extramedullary disease, which really represents an unmet need in myeloma. And also about 20 to 25% at ISS stage 3, which we know in T-cell redirection therapies has been a negative prognostic factor. When we look at the refractoriness, about 93% of patients were refractory to CD38 monoclonal antibody in both groups. And then also about 3/4 of patients were triple class refractory. And almost every single patient, 95% approximately, was progressing on their last line of therapy. So even in this heavily treated patient population, on the left, we see the response rate of about 75% in both groups. And importantly, this response was consistent across several subgroups, including ISS3, cytogenetics, number of lines of therapy, refractoriness, belantamab exposure. The one group that had slightly lower response rate was baseline plasmacytomas, but even these groups had a response rate of approximately 50%. When we look at the durability of these responses, the median PFS was 7.5 months versus 11.9 months in the 2 groups respectively. DOR, 9.3 and 13 months, and the duration of response in those patients who had had a CR or better, not reached. This reflects durable responses as well. I should add that these responses came pretty rapidly at about 1 month, and the deepest response occurred at a median of approximately 2 months. When we look at the safety, the rates of high-grade AEs were relatively uncommon, and most of these comprised cytopenias, as shown on this slide. These cytopenias typically occurred during the early parts of the treatment, or first few cycles. When we look at non-heme AEs, as shown on this table, almost very few were these non-heme AEs, and the main non-heme AEs that are of note are probably related to the expression of GPRC5D on heavily keratinized tissues, including skin, nails, and also perhaps the dysgeusia, perhaps mediated by salivary glands. So the management of skin was quite easy, topical and oral steroids as needed at the beginning of the treatment course, and thereafter quite manageable. Dysgeusia managed with hydrating agents and at times dose reduction. Cytokine release syndrome was also seen in about 75% of patients in both groups, but the majority of these were grade 1 and 2, and this is typical of bispecifics. Importantly, the rates of discontinuations due to these AEs were very low at about 5% in both groups, indicating the favorable tolerability of this agent. I'd also like to call your attention to the infection pattern in this agent. The rates of grade 3-4 infections were relatively uncommon at about 17 and 12%. And when we contrast this to some of the other therapeutics in this space, particularly BCMA bispecifics, which are demonstrating grade 3-4 infection rates of as high as 45%. Secondly, when it comes to COVID, COVID did occur in about 10% of both cohorts, but the rates of severe COVID and deaths were quite uncommon. There were 2 deaths across the entire study cohort being discussed here. And in contrast with some of those BCMA-directed therapies, we've seen significant COVID complications. Finally, the rates of hypogamma was quite low, only about 10%. And in fact, relating to COVID as well, we've noticed that the ability of these patients to respond to COVID vaccines was maintained in our laboratory. ICONS was pretty uncommon, about 10%, and quite manageable, and typically occurred in the context of CRS. The important prior T-cell redirection cohort, which comprised about 51 patients, we saw this response rate was maintained at an impressive 63%. The response in prior CAR-T was about 72%, and prior bispecific, 44%, although I would use caution from overinterpreting because the numbers here in these subgroups are quite small. The safety profile of these patients was no different than the overall cohort. So in summary, while we have a lot of exciting new therapeutics for myeloma, including several recently approved CAR-Ts and a bispecific, all of these are targeting BCMA. And what's unique about this agent, Talquetamab, is it targets GPRC5D, which is a novel antigen target in myeloma. And we still found a very impressive response rate in both weekly and biweekly schedules of about 75%. The response rate was maintained in patients with prior T-cell redirection at 63%. The safety, pharmacokinetic, and pharmacodynamics were relatively comparable between both cohorts. The rapidity of response, the depth of response, the durability of response were all quite impressive. And the adverse event profile was quite manageable and characterized by CRS, skin, nail, and dysgeusia, which were typically low grade. Cytopenias were quite manageable and were early on in the treatment. The next steps, there's a phase 3 study that's ongoing, looking at Talquetamab, both in combination with several backbone therapies, but also additional phase 1 studies are going on with Talquetamab, the other bispecific antibody, which is an exciting kind of chemo-sparing cocktail, daratumumab, IMiDs, and also a checkpoint inhibitor, PD-1. And I'd like to really thank all the patients and staff that participated in the study, and I'd like to thank you for your attention.